Hello and welcome to the Society of Professional Benefit Administrators webinar. Learn how the marketplace is responding to support self-funded plans with transparency compliance solutions. It is now my pleasure to turn the floor over to our moderator for today, Ken Vegas. Ken, when you're ready, the floor is all yours.
Good afternoon, everybody. My name is Ken Vegas. I am the president of Enterprise Group Planning. We are a 40-year plus third-party administrator, longtime member of the SPBA, and happy to be here today and introduce our guest speaker, who is Mary Piecuch from Payer Compass. We at EGP provide employee benefit services to small employers through level-funded products and representing U.S. Health and Life Insurance Company along with our stop-loss partners. But we also work with large employers in traditional stop-loss. And in doing so, we provide access to contracted PPO networks, carrier-based PPO networks. But also we've developed our own reference-based pricing provider reimbursement process, which really led us to being introduced to Payer Compass back in 2014, and it's been a pleasure working with them since that time. They have been a good, excellent business partner for us, and we're pleased to be working with them. They support our reference-based pricing program in doing Medicare-based repricing, patient advocacy work, but also and we assisted them in the development with an excellent provider search tool, which is a national provider search tool called Compass Connect. And it's with some of that technology that has been developed by Payer Compass that they are working to assist payers like us with the new demands in terms of transparency and provider identification and quoting of services to comply with the new legislation. So again, that Compass Connect tool has been effective for us in helping people identify willing providers and providing them key information about those providers. And that is sort of the impetus behind Payer Compass's reaction and development to assist payers like us in this new compliance area. So, as I mentioned, our guest speaker is Mary Piecuch from Payer Compass. And Mary is a Senior Vice President of Member Advocacy Operations and Product Strategy for Payer Compass. Mary's mission is to help organizations understand the unique challenges and divine technology solutions to improve the company's overall performance and products. She has over 30 years of unique experience in the health insurance and cost containment industry, working as a business analyst and moving into leadership positions in IT and operations for various health plans. With her sharp acumen and genuine desire to help, she is a respected member of the Payer Compass team. As a Senior VP of Product Strategy, Mary oversees product responsibility for group health, which includes reference-based pricing provider, PPO provider, preferred provider organizations, networks, and out-of-network plans. She frequently collaborates with our sales and development departments to bridge communication and prioritization between the teams for successful product creation and enhancements. Mary is a native of Chicago, Illinois, and currently resides in Warsaw, Indiana. When she's not in the office or with clients, she enjoys fishing, playing poker, and spending time with her family. So once again, I'm happy to introduce Mary. And Mary, please say hello to the group.
Hi, everybody. Thank you, Ken, so much for the introduction. I really appreciate it. So we're going to go ahead. I'm glad everybody joined us today to talk about our transparency challenges and solutions that Payer Compass has been following along very closely. One of the things we all like to remind folks, Payer Compass has always been in the forefront when it comes to building transparency solutions. So what Ken just talked about was Compass Connect. Compass Connect was our inaugural product, and I'm going to talk about that in a little bit, but it's really the platform for which we are continuing to build on transparency solutions for self-funded plans, and for, really our client and partner base. So I wanted to go over today really talking about what's happening in the industry when it comes to new regulations and walk through the timeline. Earlier this year, we had to have the hospitals and providers launch their transparency and price. It's been a unique year for all of us, not just from a provider perspective, but also the health plans. So really 1/1/2021, we're seeing about 2/3 of the providers trying to comply in one way or another. And when I say that, there are specifications about how providers are supposed to be providing their prices on their websites. It's supposed to be predominant, and it's supposed to really be easy for a consumer to digest and understand what the cost of healthcare is going to be. One of the biggest changes that came out this year, more recently on July 19th, CMS recommended that the penalty for the health providers to increase that penalty, because we are finding, or the industry is finding, that not all of the providers are really complying. So, but prior to July 19th, really the penalty was $300 a day. So for a hospital or a health system, it really equates to about $109,000 a year, which in theory isn't a lot of money, but when it comes to a health system, but there needed to be more teeth when it came to the penalties. The recommendation that's coming and has been proposed by CMS is really basing the penalty for the hospital or providers to be based on their bed count, all the way up to $2 million. So hopefully we'll see more compliance when it comes to the hospital or provider transparency that was launched earlier this year. Furthermore, our next big milestone for the industry becomes 1/1/2022, with health plan transparency for the machine-readable files for in-network and out-of-network, as well as PBMs, your pharmacy benefit managers. And then furthermore, also on 1/1/2022, the No Surprises Act is really dictating some regulations around advanced DOBs, qualified payment amounts for the provider, plan, or member. More to come on this. We did get an interim final rule with regard to the No Surprises Act that was published on July 2nd. It really focused on emergency services as well as the qualified payment amount. Pretty significant gaps in some of the rulemaking that was expected with regard to advanced DOBs, the price comparison tool, the independent review process. So more to come on that. And then furthermore on 1/1/2023, really from a Transparency and Coverage Act, having consumer-facing shoppable services for the initial 500 CMS-defined services, and then as of 1/1/2024, all services from a health plan perspective have to be shoppable. So this is just a high-level run-through of some of the major milestones that we're facing or challenges that the industry is facing in the next couple years. So really wanted to talk about what's changed since the issuance of the interim final rule. So really what was focused on, what I just alluded to during the timeline, was really the qualified payment amounts, really how those are going to be calculated or how they can be considered, was a big part of the interim final rule, as well as emergency services was definitely part of the interim final rule. So really giving guidance as to what the initial payment or the median rate needs to be calculated, what it means to be sufficient data to calculate the QPA. There was further guidance, especially from those of us that are supporting self-funded companies or health plans, really taking it and making the data set more broad, so that when you have a self-funded plan, a lot of times their data might be definitely more narrow than a large commercial payer. In the interim final rule, it was discussed that a TPA can really aggregate their data across their book of business so that they can obtain that sufficient database of information in order to calculate the QPA for a specific metropolitan service area, so the MSA. So that was a very large part of the interim final rule that came out July 2nd. What was surprising was not a lot of information on some of the really larger lists when it comes to a technology perspective. So the advanced EOB was definitely one that folks were hoping to see come in this interim final rule, because there is a lot of development from a technology perspective, as well as there is language in the No Surprises Act with regard to a price comparison tool. You know, in talking and following up with the different lobbyists or organizations and the industry forums, there really isn't a whole lot of guidance other than the fact that the regulators are expecting that, you know, in good faith effort, the health plans comply in lieu of having all of the interim final rules or the rulemaking complete. So this was released again at the beginning of July. We are expecting additional interim final rules between now and the end of the year that would cover the IDR process, the advanced explanation of benefits, the price comparison tool, and a myriad of a few other good handful of topics. We at Payer Compass are participating in some of the industry forums, sitting on the work groups, and we're following this along very closely. Okay, and then we'll move on. The next one topic that we really wanted to cover here was what was covered in CMS's proposed rule for hospital provider transparency. So really the intent for the hospital provider transparency was really showing that we have the different prices being provided to consumers so they can make good choices, but also from a perspective of protecting the medical consumers, the members that are in our health plans. So really making sure that we're allowing what we would do in any other industry within our different health plans, the ability to shop, the ability to pick different providers in order to, and also looking at different procedure codes, what the cost would be, really looking and seeing that we have all that information in front of the healthcare consumer so that it is transparent, not just from a health plan perspective, but also from a provider's perspective.
Mary,
yes.
you mind I throw a question out there that I think might be on everybody's mind. And
Sure.
Can you describe, in your opinion, the usability, the readability of the data that providers have published so far in compliance with the requirement back in January 1st in terms of disclosure of their pricing? How usable, is their disclosure, and how do we connect that, depending on your answer there, with the information that will be needed, down the road here when we need to actually publish pricing for plan participants?
Yeah, that's a really good question, Ken, and from whoever submitted that question. So it's a pretty wide range of how usable the data is. I know that myself and our development team have been looking and inventorying different hospital systems websites in order to consume these files. You have some hospital systems that are doing a really good job. They're doing what's expected, providing a price per service and what the minimum and maximum would be, really what was dictated in the regulation. However, you do have a lot that are not providing that clarity of information. They're using codes that would be more specific to the health system versus an industry standard perspective. So it's really not clear, and I think that that's where we're getting this additional teeth into a penalty for the hospitals or the providers in order to be more clear. I know from a perspective of a health plan, because creating the machine readable files It's fairly specific, and I'm going to qualify my answer, fairly specific. So CMS has a GitHub website in which it dictates what the health plan machine readable files need to look like. There's two specific formats, JSON and XML, in which we can produce the machine readable files. You know, there is some, or I shouldn't say some, there's quite a bit of chatter. There is a discussion board within that website that does talk about different attributes or elements of the file that weren't really clear, perhaps not as specific as some of the more seasoned health plans or technology organizations would expect. So a good example is those machine readable files are the definitions on the CMS GitHub, missing modifiers, for example. It's been tough, but I think folks are really taking to heart what the actual machine readable files are in order to produce those with a good effort to comply. So I'm gonna, so there's a little bit difference there. We're not getting a whole lot of compliance when it comes to the hospital or provider transparency. However, you know, that's where that recommendation for increasing the penalty is coming from. And then from a health plan, really, we're still working through the logistics of that JSON or XML machine readable file format on CMS's GitHub site. The outcome of all this data is so that all of these, the data elements can be brought together so that we really can get a good understanding of what the healthcare costs really are, between understanding what the actual prices are from a provider perspective, but also what are the negotiated rates from a health plan perspective. So really lending itself to building, you know, whether you want to call it a qualified database or having sufficient information for really understanding what is the true price for healthcare in any given geographic area, and more so building up our data sets so that we can get to that QPA beyond what we would have in our own negotiated rates. Ken, does that answer your question? I hope so.
Yeah, it does. Thank you. And maybe a quick segue sidebar, if you don't mind. There is a question in the chat box about the transparency machine readable, and the question is the compliance based on when the plan year starts, i.e. 7/1/22, or for all on January 1/22?
So that's a really good question. So for 1/1/2022, the machine readable files are actually based on your negotiated rates. And so, you know, how we're looking at it from a perspective at Peer Compass when we are creating the machine readable files for our partners, it's really taking into consideration our negotiated rates based on the prior month of all contracts that are loaded and making sure we extrapolate all that information into the machine readable file. So really, it is for 1/1/22. I think that there is some, I don't want to speak for the regulators, but if you look retrospective of what happened here in 2021, the regulators did allow for that leeway at the earlier part of the year, and where the auditing really stepped in was around the May timeframe. And so between May and now is where you're getting the feedback from the regulators in order to, number one, increase compliance. And then here, you know, the stick in order to get that compliance is increasing the penalties.
Yeah, I think the question was if a plan's anniversary date, renewal date, if their plan year doesn't start until July 1, 2022, is that when they need to begin complying, or do they still have to begin complying on 1/1?
No, it would be based on when they're, so it's for the plan years starting 1/1/2022 and beyond. So okay. Yes, if they are July 1st, that's when they would have to start complying as a health plan.
Thank you.
Yep, no problem. So going back to what was covered in CMS's proposed rule for hospital provider transparency, so I think I kind of explained that, what the intent was, and really kind of talking about, again with Ken's question with regard to the machine readable files, it really is to gain that transparency so that we have consumers that are able to shop around, not just for price, but eventually, the vision would be that just like anything you would buy from a consumer perspective, you can determine quality, the provider that you would want to see, and also based on, affordability. What is the price of a service? And so you can compare it. A good example there is also, say, for example, an MRI. Whether you get it in a hospital, you would be able to shop what is that MRI going to cost at the hospital versus at a freestanding facility. Okay, I'm going to continue to go through just to make sure that we can get through all of our topics that we wanted to cover. Transitioning the written rule to its solution applications. So, again, when we're looking at technology, it's looking at the basis and how I know we're looking at it. I'm going to pause for 1 second because I also see another question. So the question coming in is, how are you handling % off contract arrangements and contracts where a contracted rate is based on an ASC type of arrangement? So there is a lot of, that's the question that just came in. So I'm going to go back to machine readable files here before I dive into some of these specific, actually it kind of goes hand in hand with the third bullet here for the machine readable files. So from a % off bill charges, or say, for example, a % of Medicare. So in the actual file itself, it doesn't lend itself to giving a percentage off bill charges. So some of the discussion board that is occurring is talking about, instead of actually putting a dollar amount, putting in some additional information as to 80% in the actual amount versus actually trying to extrapolate, 80% of bill charges, because you don't know what bill charges are until the actual claim comes in. So that's one thing that to be really clear about. You really have to watch what's going on with the CMS GitHub website to make sure that you're following along as to how folks are interpreting or working the discussion boards. So the answer I just gave was a result of watching that discussion board about how people are going to handle certain situations for which that file format wasn't perfectly designed. So folks are talking about putting in comments such as 80% of bill charges versus an actual dollar amount. And then furthermore, if you have a % of contracts, so say for contracts that are based on Medicare rates, so say, for example, you have a provider that you have 135% of Medicare is what your negotiated rate is. You actually, for your in-network file, you have to extrapolate that out into an actual machine-readable file. Even though, industry-wide and it's published from a CMS perspective, you could say, go look at CMS and times it by 1.35. Not allowed. Regulators were very specific that you cannot do that when it comes to using a reference base like Medicare. You actually have to populate the file when it's readily available. You cannot use PDFs, and you can't, like I said, reference it to a standard such as Medicare. So I hope that answers the question for the participant. So I want to go back to make sure we hit on each one of these topics. So really defining solutions that fit how to be compliant with these transparency regulations or the No Surprises Act. How we're looking at it from a payer compass perspective is you start with the provider. So our inaugural product was really making sure we have provider transparency. And then, of course, price transparency. Price transparency is what we've been talking about here a little bit on the call already, where you have your in-network negotiated rates so that a consumer can go out to a tool, a web-based tool, or make a phone call to their health plan in order to understand what the services would cost. So that's really the impetus of what price transparency is all about. The machine readable files, making sure that we make those files accessible so that we're all contributing to the what we would call the greater good of the medical consumer, and really understanding what the prices are, what the negotiated rates are versus or in comparison to what the provider rates are. And then, of course, the advanced DOB is something that you have to build up on there. So once you understand who the provider is, what the price transparency is, what the price is for the service, whether it's from a perspective of the facility or hospital or from a health plan, in theory, you could make your machine readable files synonymous so that you're able to handle identifying that price transparency more efficiently, and then layering on there the advanced DOB. So again, from a No Surprises Act, we got the regulation that, health plans have to be able to provide an advanced DOB. I know I've talked about this in other forums in the fact that, the dental industry was a little bit, well, probably more than a little bit, a lot more advanced in the fact that when you go in for your standard cleaning or your more typical dental work, you know what you're going into as far as a dentist. When you have to get more complex or major work, there's a dental predetermination that gets created. It's a pseudo claim that the dental provider is very familiar with. They send that into the dental carrier and they get a predetermination of benefits, what you could also refer to as an advanced EOB, because really what they're outlining is the service covered? What's the allowed amount? What's going to be paid on it? So what the regulators here are expecting is that the medical industry would follow suit in the fact that here, if you understand what the services are going to be, somebody's going in for a knee replacement, and really the regulators are very clear in the fact that these are good faith estimates. There's definitely room for change, as we all know. If you go in for a medical procedure and you have an episode of some other comorbidity or other medical condition that comes into play that changes maybe the course of what that hospitalization or procedure was supposed to be. But really, the regulators are saying in your advanced DOBs, providers, it's supposed to start with the providers so that they can provide the information to the health plans. The health plans, in turn, take that information. They're able to determine, need to be able to determine whether the procedure is covered or not, what the negotiated rate would be, what the cost share to the member would be, and then, of course, apply the appropriate disclaimers that these are good faith estimates. And then the qualified payment amount. The qualified payment amount is coming in from two perspectives. One is when a provider appeals their reimbursement, they should have the ability to appeal it. It was clear in the Interim Final Rule that from a QPA perspective, the burden of proving that the reimbursement was not appropriate falls on the provider. However, the health plan needs to be able to come to the table in an independent review with a qualified payment amount. And really what this is determining a median amount for a service in a geographic area. And so during that IDR process, the qualified payment amount can be determined and analyzed between the information that the provider appeals with, as well as what the health plan is able to bring to the table to say, hey, in this general metropolitan service area, this is what we're typically getting for the same service for the same type of specialty. And therefore, we're able to justify why we reimbursed from a health plan perspective, what we reimbursed. The other place where the qualified payment amount really comes into play is on the emergency services that are coming out of the No Surprises Act. When you have an emergency episode, the No Surprises Act, the Interim Final Rule, was pretty specific, in fact, very specific, that from a health plan perspective, you can't simply say emergency services are based on a certain diagnosis code or a place of service. It has to be based on a prudent layperson, whether they felt that their situation or health condition was in peril, and therefore they needed to go to the emergency room. Once the member goes to the emergency room and they're diligent about going to an in-network facility, because that's the provider that was near their home or where the accident occurred or illness occurred. You have all those other services during an episode of care that are occurring. So you could have an anesthesiologist, a radiologist, a pathologist, your ER doctor. Typically, those are not, contracted entities when you're in the ER or facility, and it's really not a member's, they can't control that. So the No Surprises Act is really dictating that when you are in that emergency episode of care and you are at an inpatient facility, that your other ancillary providers need to be treated as if they were in network, meaning they're getting the same type of reimbursement as another in-network provider for the same service in the same area. So this is where, a good example is for that ER doctor, if he's a general practitioner, if he's an orthopedist, if he's not contracted, you need to be able to determine what the QPA is for that metropolitan service area for that orthopedist so that they can be reimbursed based on an in-network occurrence. And then it goes further into, you're utilizing your QPA from that perspective, as well as your cost shares need to go towards the members' in-network accumulators, deductibles, and copays. You cannot penalize a member because it was an emergency service. So really, these are some of the high points that we're talking about, especially from a payer compass perspective, that came out of these regulations. I'm going to go into, because it looks like we have a couple questions regarding tiered networks in a specific tool and some other questions. I'm going to answer this other question first. It sounds like that the PPO must provide price transparency as they know what a medical provider's allowance for services is, correct? This is a dicey one. So if you have a PPO network, if you are looking at the regulations, whether it's transparency and coverage or the No Surprises Act, and really it's when you're talking about the price transparency for a PPO, it's talking about that transparency and coverage and the regulation for the machine readable files. As we all know, PPOs really don't like to disclose their arrangements. In general, no health plan really wants to disclose their arrangements with a given provider. However, there really isn't any penalty for a PPO not to comply, which is, a definite misstep in the regulations because it really puts the burden on the actual health plan. And with that being said, and I know that I've participated in several of our partner discussions, well over 30 different discussions with regard to this. And, as a good partner, Payer Compass, we're working to support our partners, but really the PPOs, I think are maybe begrudgingly willing to also support their health plans, but really from a perspective, there's nothing as far as a penalty in the regulations for the direct PPO entity. The penalty is based on the actual health plan.
Yeah, Mary, if you don't mind, let me chiming in.
Yep.
This is kind of an elephant in the room because Mary's right. The compliance requirements are for the plan and the plan sponsor to comply, and they rely on the payers to fulfill that requirement for them. The payers rely on the PPOs to provide access to contracts, but generally try to keep that proprietary. There is a disconnect there. I would suggest that you reach out to the PPOs that you're using and see what kind of work they're doing on this, see what kind of information they've agreed to make available. I would presume each one of them has to address their contractual arrangement with the health systems that prevents them from disclosing information because the marketplace is going to demand that they assist in providing access to that. So, that is a tricky one, as Mary described, but I would I would suggest you reach out to the PPO networks you're utilizing and put some pressure on them and ask what they're doing.
Yep, absolutely. Okay, so we've talked about some of the high points in which we have to define solutions from the industry perspective. I'm going to go a little bit more specific into how we at Payer Compass have been looking to fulfill these compliance requirements and working with our partners. So our tool, what I talked about earlier, and what Ken also talked about earlier, which he's already engaged in using for his plans, is a tool called Compass Connect. So Compass Connect was a tool that was actually, the working tool was the transparency tool before we actually branded it as Compass Connect. It was something that Payer Compass was working on well before these regulations actually became into law or were signed into law in the last year. So the first tool was the provider transparency. So really making sure from a medical consumer perspective that the member or patient could have an application in their hand that says, give me all the providers in a certain geographic area that are for a specific specialty. So really making sure that we're helping the consumer understand where they can go for care, how they can look and compare providers from a quality perspective. So say, for example, you want to find a dermatologist in a certain area, say, for example, the Chicago area. And that dermatologist, you want to see from a specific city and state or a zip code, what dermatologists are accepting of your health plan. And so it was made really simple so that a medical consumer, not all of us who are, in the industry or grew up in the industry can talk super fluently, but a member can assimilate it to, for example, like a traffic light. So if the color coding on the provider for that dermatologist in that geographic area is green, then the member knows that they're already an accepting provider or of their health plan. And then they can take the additional information that's in the actual tool, such as where they're located, what their quality scores are, because it is integrated in Compass Connect today. So you have the geographic location, the type of provider, and then the quality scores. And then the whole user experience was that there is that ability to compare the providers, including prices, receive their care, and then in our roadmap is really have a place for the member or patient to come back to within Compass Connect and give their patient experience. So think about it as, your restaurant applications when you actually go seek out a specific restaurant in a geographic area. You have dinner, you either had a good experience, bad experience, or you wanted to kind of share with folks what your experience was. That was really the intent of Compass Connect, is really to have this full user experience with the actual member or patient's needs in mind specifically. I'm going to continue going on here because I really want to make sure that we are talking about all of these solutions together. So when we're talking about facing these transparency challenges, or if you want to be more optimistic, opportunities, provider transparency is something that Payer Compass has already put out into the marketplace. We launched it on July 1st of 2020. As Ken stated, he's using it already for his health plans with a positive experience. Our intent is to go ahead and build the price transparency on top of that. So we're checking the box off, not only for the transparency and coverage rule, but hopefully we'll get more guidance. In the No Surprises Act, there is actually a price comparison tool regulation as well. And then the advanced DOB, really understanding who the provider is, what the price is, and then being able to provide that estimate, a good faith estimate to the users in the advanced DOB, or what the industry is calling the AEOB. I'm going to answer a question. So we have a question here is, how will you handle tiered networks in the tool? So one of the things that we took into account from a Compass Connect perspective is making sure the tool itself is customizable. So our default setting is, like I said, it's more from a perspective of a traffic light. So easy for someone to be synonymous, and green means good, yellow means proceed with caution, red means you might want to steer clear of them or go in eyes wide open that you could be balance billed or they're not accepting the health plan. So from a tiering perspective, we do have the ability to configure our networks. So we can add in, for example, another layer or color within our transparency tool, Compass Connect, to say perhaps tier 1 providers are your preferred providers, and we can give them a different color coding. And based on your requirements, we can configure the tool to make sure that it displays your providers to meet your plan or your philosophy for your plan. Okay. So really, we've been focusing on that consumer solving the member challenges to make sure that they have a tool in their hand that really brings this all together. And, you know, to pitch Payer Compass, please reach out to us either via our website or a partner, sales partner for Payer Compass, or myself, because you'll have our information for more information or for a demo, because it is going to be a game changer in the industry for sure. The other part of our solution is producing those machine readable files. So for 1/1/22, our development team is actively working on producing and being prepared for producing the machine readable files by 1/1/2022. From a Payer Compass perspective, if you're already a partner or looking to be a partner, we have a phenomenal platform called Visium, in which we do contract management. And the fact that a lot of our partners are using that particular tool for their pricing, it is the impetus of how we would create the in-network files. The fact that we load the contracts and we're already pricing claims, we will go ahead and use our algorithms and our logic in order to produce the in-network machine-readable files based on the contracts that we have loaded. If you're a new client, we would work with you on loading your contractual arrangements in order to produce the machine-readable files. Furthermore, we do price a lot of our clients' claims, millions of claims a year. Therefore, we are able to produce the out-of-network file, which really focuses on claim information. Really, the out-of-network file is looking for what was billed by a provider, what is the allowed amount for a provider. And as long as we're pricing the claim, we have that information. And in our workflow of actually creating that out-of-network file, we also can receive supplemental information from our partners in an 835 or a predefined file format. From a pharmacy benefit manager perspective, we haven't been approached as to have to create those. Normally, we're hearing that the PBMs are really creating their files. We can provide the service of also hosting the site where you can have all of your machine-readable files made available, or aggregating that data together. So really, this is our complete solution set from a Payer Compass perspective going forward. I'm going to look over here. Looks like we have a couple more questions. Let's see, we have, for AEOB, is it your opinion that AEOB requests would have to flow through the provider, or do you think the member will also have to be able to request an AEOB directly from a health plan? Really good question. So if you look at the No Surprises Act, the intent was that it would start with the provider, meaning the provider has to provide the actual codes of the service so that you can discern what the price would be, what the benefit allowables would be, if there are any copays or deductibles that would be applying. So, but it's also kind of, again, kind of what we were talking about a little bit. It's kind of another elephant in the room, so to speak. Providers are always a little bit hesitant to give up those codes because it's not a given of what's actually going to occur when they have or are providing services. At Payer Compass, we do have an advocacy team in which we are often working to negotiate or work with and gaining acceptance to providers. And we often have these types of conversations with providers so that they can understand what their reimbursement amounts would be. It's not easy to get the providers to really give you those codes in order to negotiate with them. Our team does a really good job of working with them, but again, here, there's no teeth in it for the providers to comply to make sure that information is provided. From a payer compass perspective, because the price transparency and the advanced DOB functionality is going to be built within Compass Connect, it will and is going to be a facing tool for the member. So if the member does have the codes or they're intuitive enough to figure out their codes, some of us work in healthcare but maybe need the tool, the member could shop using Compass Connect in order to get prices and, in theory, generate an advanced DOB. But really, it is supposed to start with the provider so that, you have the actual codes and you could discern the price and the benefit levels and reimbursements. Looks like we have another question. Out-of-network ER claim adjudication process. I'm trying to read. Let's see, it's a big question, so I'm going to read it out loud just so everybody can hear. Out-of-network ER claim adjudication questions. I believe the IFR, Interim Final Rule, provides that the plan calculate cost share based on the QPA. That's correct. Then it goes into paying the out-of-network provider at the out-of-network rate and does not specify QPA. Well, so if you go and look at the regulation, it basically states that you have to treat those other providers as if they are in network. So it's not like you're going to have a negotiated rate for that provider, like the ER doctor when you're in an in-network facility. So you have to discern what that rate would be. QPA, in theory, would be the right rate to go out of the box so that you don't have that appeal. But I would refer you back to the No Surprises Act. I think, especially in the Interim Final Rule, I think it was pretty clear they really want those other providers treated or reimbursed, in a similar fashion as the in-network rates for that given metropolitan service area.
Yeah, I think from a big picture standpoint, the point is you have to pay it as an in-network provider at the same benefit level. Mm-hmm. And as long as you're paying it at the QPA amount, the provider is responsible for accepting that. Of course, you may get in a position where you have to document and demonstrate that you paid it at that amount. But the whole theory behind it is to eliminate balanced billing and conflict. You pay it at the in-network rate, pay the qualified payment amount, and the provider should accept that. Is that right, Mary?
That's what I would say too. Yep, exactly. Okay. Some of the other information that we provide here is really giving some additional helpful resources. As I alluded to a few minutes ago, we do have the GitHub website and the CMS newsroom are really important places to follow. You can definitely use additional sources, but as far as the machine readable file is concerned, this is the link for the GitHub site via CMS. I encourage especially the technical participants in your health plans to follow along or subscribe to the discussion board. I get numerous emails every day because it will alert you as new topics are coming in and what the dialogue is between the users are. And then, of course, CMS is following along in what these discussions are, and they are updating as best they can solutions or interpretations of how you can update and add the content to the JSON or XML files. There is a lot of dialogue going on, so I'm not going to lie to folks here on the phone. It does produce a lot of emails, but it is interesting to keep up with it instead of having to go back to the actual website itself on a regular basis. I take a look at it every day just to see what the topic of the day is and what the back and forth dialogue is. And of course, the CMS newsroom. There is going to be additional interim final rules that are going to be coming out this year. It's going to be a pretty, we hope, a pretty swift interim final rule period where the different industry forums are going to be looking to provide comments back to CMS based on these interim final rules. I know for, excuse me, the forums that I sit on the work group for, they're already kind of warning us that we're going to have to turn around our comments pretty quickly because, you know, our runway to 1/1/2022 is becoming shorter day by day. So they're just all warning us, you know, those comment periods are going to go pretty quickly. So keep your eyes out for the additional interim final rules that are coming out this year. Ken, those were our slides for today. I don't know if you had additional commentary or thoughts that you wanted to bring to the table while we have just a few more minutes left.
Well, I do see one other question out there.
Okay.
We missed from Tom. If a plan is a hospital plan, I presume for their own employees, with a domestic network, and so their rates are considered to be tier 1, how can that be built out? And I suppose as long as there is, you know, full disclosure of what those contracted tier 1 rates are, then, you know, it can be built out as any other tiered network would be. Wouldn't you agree, Mary?
I would absolutely agree. Yeah, I know, you know, from our environment at Payer Compass, it's very configurable. And like I said, from a Compass Connect perspective, as far as a tool, we did make it so that it could be configurable and you have different tiering as long as partners can produce the logic as well as identify who those providers are for those given health plans, it can be configured.
And I think we've addressed all of those questions. I guess one remaining question I'll throw out there, Mary, to see if you have an opinion on it. You know, I've seen some commentary that, you know, because of the heavy lift and the less scalable infrastructure of the hospital systems in terms of providing pricing data available, that there and I know we can't count on it, but there is the possibility that, you know, some of these provisions that are on queue to be effective for 1/1/22, you know, could be delayed. And I guess it's all going to depend on when the regs come out. But, you know, is there chatter about that? What's your opinion on that? And I know we can't rely on that. We have to prepare.
Yeah, exactly. Ironically enough, I just today ran into this because we're working really closely with our partners, and while the only rulemaking, the interim final rule that came out for No Surprises Act was on July 2nd so far, and it really addressed the emergency services and QPA were the highlights. Right. And some of these other, you know, technology plays such as the advanced DOB and the price comparison tool were not addressed. And so I did reach out more recently to some of our, I guess you can call them the lobbyists for some of the groups, as, you know, the regulators basically are expecting that, you know, you do your best in good faith to comply with the regulations, even without very specific guidance. So don't rest on your laurels waiting for them to tell us exactly what to do. We should be moving forward with contingency plans in order to put the minimal solution out there. But there definitely could be some delays, but it's not guaranteed. So I got kind of the double-edged sword answer when I more specifically recently asked that question.
Well, thank you, Mary. Very helpful. As I said earlier, we very much appreciate your organization as a resource for us and helping us support our plans, our clients. And appreciate your expertise on this, and thanks for staying so well engaged for all of us that rely on companies like yours.
Great, and thanks for being a good partner, Ken. We really appreciate it too.
Our pleasure.
Great. I hope everybody has a great rest of the day and continue to look for the updates and information from SPBA.
Great. Thank you so much, Mary. Thank you so much, Ken. Before you all log off today, we ask that you take a brief moment to fill out a survey that should appear on your screen momentarily. It really goes a long way in helping us plan for future events, and we certainly appreciate your feedback. Again, a big thank you to Mary and Ken for their excellent presentation, and I'd like to thank our audience for joining us as well. This does conclude today's event, and we all hope you have a great afternoon.